I would request Dr. Sudeep Das, the head of Shankara, for giving us tips about hydro dissection, how to make things easier in a topical FICO. Thank you, Dr. Sudeep.
Actually, this is supposed to be my friend Mohammed Sayee. He couldn't come, so I'm presenting on his behalf, but this is actually my presentation. So this was the cortical cleaving hydrodissection was actually first described by Dr. Fine in 1992, and how he described it was inject fluid under the anterior surface of the anterior capsule gently but continuously with a 26 gauge cannula, and this fluid sort of goes peripheral to the cortex, between the capsule and the cortex, goes around the equator, goes around the fornix, and then behind. So basically dissects the entire capsule from the cortex and creates a sort of a lake of water behind the nucleus. And then what you do is you go to one side and depress the nucleus down. So when you do that, this fluid comes out 360 degrees from all around, and that is what causes the cortex cleaving hydrodissection. So the important thing in this is that the first thing is you have already filled up the anterior chamber with viscoelastic, with OVD. So it's tight with OVD because you want to do a rhexis. So when that is there, it's like a bung stopping the wound. So when you inject further fluid, it's not going to come out. The fluid is not really going to be very effective because this OVD cannot come out. And if you keep injecting any more fluid, the weakest point is the posterior capsule, that will rupture and the fluid will go into the vitreous. So first you have to wash out some of the OVD before you start. And then you inject the 26 gauge cannula almost at the equator, you can't see the equator. And then you lift the anterior capsule up slightly, tent it up. And then you inject BSS till you see a fluid wave behind the nucleus. And stop injecting the fluid when it reaches the opposite side. Then gently depress, go to the opposite side. So there is, people talk about multi-quadrant hydrodissection. Actually, it's enough if you do it from one side. Go to the opposite side and depress it, and you'll see the actually fluid coming out from all sides, and the red glow becoming a lot less. And then you can rotate the nucleus very freely. If it doesn't rotate, then you can repeat the hydrodissection in some other quadrant. So here you see this is in full speed, and I'll show it again in, so burp out some of the viscoelastic, then that's a fluid wave, come to this side, just depress and move it to the same side that we injected from, and it will rotate. So now this will be in sort of half speed. So you can see this fluid wave starting there and coming to the opposite side. You stop at this point, depress, come to the opposite side, depress, and move the nucleus again to the side you injected the fluid from, and the fluid sort of comes out. And rock it a little bit, and then you can sort of rotate the nucleus very well. So this is a slightly harder nucleus. So same thing, only when it's, as the nucleus becomes harder, you need to inject even less fluid because the nucleus takes up more space. So sort of move it, and then if you've done it well, it will sort of rotate very easily. Otherwise, you can go back and rotate it again, inject again. So this is a sort of a fairly hard brown cataract. So again, burp out some fluid, inject, and these actually rotate even easier. This is a very soft cataract. So what do you do in these? These are the most difficult. So here you do the same hydrodissection, cortex cleaving hydrodissection, but then you have to do a hydrodelineation, because otherwise, so at least when you're doing phaco, you can remove the central part of the soft endo, which is slightly harder, the endonucleus, and the rest of the cortex. Otherwise, you end up sort of, sort of removing it piecemeal, and it becomes very, very difficult. This is a PPC. So here you do not do a hydrodissection. You sort of dig into the nucleus and into the cortex rather, or epinucleus, And then, as you saw, you sort of do a multi-level. I've done it in 2 levels here. So that is like one golden ring you will see, hydro delineation. Then go a little further. Again, you can do even 3 of them if necessary. And you try to pull out these bits first before you tackle the rest of it. And this is, of course, a very hard, dense cataract. So here you really do very minimal. You can't make out a fluid wave, but you can see the nucleus getting lifted up a bit. So you stop at that, and then you sort of rotate it. Don't be over enthusiastic about the lift. So just wait for the nucleus to come up a little, and then start rotating it. And then this is the other extreme that you'll face. It's a very intumescent cataract. It's a water-filled cataract. So here, don't even try to inject anything. There's already fluid. So all you seeing me do is sort of rocking the nucleus from side to side, and that's it. So it will sort of rotate before that. So you just go in and just rock the nucleus from right to right to break the connections. Absolutely no need to inject any fluid, because you might rupture the posterior capsule by injecting any more fluid. It's already such a swollen lens, and you can rotate it easily. So this is another very intumescent cataract, but that was a soft cataract. This is intumescent, but there is a dense nucleus. You can see the color is not that white here. So here I'm trying to rotate it again without hydrodissection, and it is possible. So anytime you have this loose, fluffy cortex, don't try to do a hydrodissection, even if the nucleus is hard. This is an absolutely dense cataract, very, very leathery cataract. So again, you wait for the slight elevation here on one side. You can see, and then don't inject much. Try to rotate, and again, it sort of works. If it doesn't, then you go ahead and do a hydrodissection. So the take-home points would be: a properly developed hydrodissection fluid wave must travel between the nucleus and the internal, so basically the inner surface of the posterior capsule, and you see that fluid wave. And this not only permits rotation, it sort of breaks up all the adhesions, epinuclear and cortical adhesions with the capsule. And once you've done your phaco, you will have very little cortex and epinucleus to actually remove. If you've done your, and if you saw, I don't do a hydrodelineation in any cataract other than a very soft cataract. So I don't have to remove the epinucleus separately again. So I remove the nucleus, there's very little cortex also left, and no epinucleus. And remember that you can rupture the posterior capsule while doing this with the hydro if you are very enthusiastic about it. But to do that, the nucleus has to go and get stuck against the rhexis. Only then there's no fluid egress out from the capsular bag. So once that happens, and it's a sort of a dense cataract, that's when the capsule ruptures. And once you sort of depress the nucleus and rotate it, you sever the rest of the connection, and your hydrodissection is done. Thank you.
Thank you very much, Dr. Sudeep, and a special thanks to you for last minute covering up for Dr. Mohammed Sayee. Yeah. Thank you very much.